Today we will be discussing chronic kidney disease. Chronic kidney disease is the end result of all the renal syndrome, may it be primary or secondary due to systemic causes. And in nephrology, if not 70%, at least 60% of the nephrologists deal with continuously deal with problems of chronic kidney disease. So it's a very important topic. Now, today, what we will do is we will define chronic kidney disease, then we will elaborate the stages of chronic kidney disease, the common risk factors for chronic kidney disease, causes of chronic kidney disease, common causes of chronic kidney disease, clinical manifestations. This we will be discussing in detail, and the routine investigations which are performed in patients of chronic kidney disease, and briefly the management, and finally the key points. Now, you see, previously the definitions of chronic kidney disease and acute kidney injury were very simple. Chronic kidney disease was called CRF, or chronic renal failure, and it was a progressive and irreversible decline in kidney function. Similarly, acute kidney injury, which we have already discussed, was defined as sudden and potentially reversible decline in kidney functions. But these terms are no more used. Instead of chronic renal failure, we use chronic kidney disease. And instead of acute renal failure, the term nowadays used is acute kidney injury. We have already discussed acute kidney injury, and we have defined acute kidney injury. We have established the diagnostic criteria and stages of acute kidney injury. Today, we will be discussing chronic kidney disease in detail. Now, the previous definition of sudden and gradual and progressive loss of kidney function is no more valid. Now it is defined as kidney damage for more than 3 months. You have to remember this period, 3 months, because if you can recall, during the lecture on acute kidney injury, ESKD was defined as kidney abnormality or kidney failure for more than 3 months. So it is ESKD is basically a chronic kidney disease. End-stage kidney disease is a chronic kidney disease. Now, kidney damage for more than 3 months due to structural or functional abnormalities of kidneys. The interesting part is with or without decrease in GFR, because the general impression is that chronic kidney disease patients usually have decrease in GFR. No doubt, most of the patients of chronic kidney disease do have decrease in GFR, which is progressive, but there are patients whose GFR is maintained and yet they have got chronic kidney disease. How come? Any patient having a decreased GFR or glomerular filtration rate of less than 60 ml per minute for more than 3 months, we have already discussed, with or without structural damage. Now, to simplify the definition, we can say that kidney damage or decrease in GFR of less than 60 ml per minute for more than 3 months, or persistent proteinuria or sediment for more than 3 months. Now here, to give you an example, that suppose there is a patient of nephrotic syndrome. Now his GFR is above 100 ml per minute, normal kidney functions, but he is persistently passing protein in his urine for more than 3 months. He is not responding to the treatment, and he is showing persistent proteinuria. Then that patient will be classified as chronic kidney disease. Similarly, a patient of nephrotic syndrome, whose nephrotic syndrome is not being resolved and is passing proteinuria and hematuria for more than 3 months, he will also be classified as chronic kidney disease. So you have to remember this definition: kidney damage or GFR of less than 60 ml per minute for more than 3 months, or there is a persistent proteinuria and sediment for more than 3 months. I hope the new definitions of acute kidney injury, the referral criteria for acute kidney injury, and the new definition of chronic kidney disease is now well understood. Now, based on the estimation of GFR or eGFR, eGFR is estimated glomerular filtration rate, and GFR is 24-hour creatinine clearance. This is the gold standard, but cumbersome, not usually performed because the patient has to collect 24-hour urine for estimation of GFR. Instead, we use eGFR, which is estimated glomerular filtration rate by the equation which we have already discussed, Cockcroft and Gault equation, MDRT equation, and the latest one is EPI equation. So on the basis of eGFR, the chronic kidney disease is classified into different stages. Now, these are the stages of chronic kidney disease. Now, suppose there is a patient who has got normal or increased GFR more than 90 ml per minute or more than, in fact, 120 ml per minute, but he has persistent proteinuria or hematuria for more than 3 months. It is the stage 1 of chronic kidney disease. The stage 2 of chronic kidney disease is GFR between 60 to 90. For convenience, I have, instead of using the symbol 89, I have set between 60 to 90 ml per minute. GFR is less. It is called a stage 2 of chronic kidney disease. The moderate stage of chronic kidney disease is when GFR is between 30 to 60 ml per minute. And the severe stages, which is called stage 4, is GFR between 15 to 30 ml per minute. And stage 5 is GFR less than 15 ml per minute, or patient is on renal replacement therapy, made in the form of hemodialysis, peritoneal dialysis, or kidney transplantation. So on the basis of GFR, these stages of chronic kidney disease have been developed by National Kidney Foundation, which is a kidney disease and outcome quality initiative, KDOQI guideline, into 5 stages. Stage 1, GFR above 90, but with functional abnormality. Stage 2, GFR between 60 to 90. Stage 3, between GFR between 30 to 60. And stage 4, between 15 to 30. And stage 5, when GFR is less than 15 ml per minute. So ideally, any patient who has got a GFR of less than 15 ml per minute should be on renal replacement therapy. Now, what are the risk factors for chronic kidney disease? You see, any systemic disease like autoimmune diseases, SLE, rheumatoid arthritis, Sjogren's syndrome, multiple myeloma, etc., or any chronic disease like diabetes, mellitus, hypertension can lead to chronic kidney disease. These are the most important risk factors for chronic kidney disease: diabetes and hypertension. In fact, almost 70% of the patients who are of chronic kidney disease, they suffer from either diabetes or hypertension. These are the 2 most important risk factors. Obesity is also an important risk factor. Family history, for example, patient has got polycystic kidney, there are chances that his offsprings or siblings may have polycystic kidney disease. Chronic use of tobacco can also lead to chronic kidney disease, and heavy consumption of analgesics, example NSAIDs, or any drug which is taken for a long duration of time can damage the kidney. So these are the common risk factors for chronic kidney disease, but you have to remember diabetes, hypertension, obesity, family history, tobacco use, or heavy consumption of analgesics or any drugs or toxins. Now, what are the causes of chronic kidney disease? As I have already told you during the lecture on acute kidney injury, any cause of acute kidney injury, if not adequately treated, and if it is prolonged for more than 3 months, can lead to chronic kidney disease. All causes of AKI, if not adequately treated, can lead to chronic kidney disease. But in addition to this, the common causes are diabetes and hypertension, because they are the risk factors. Glomerulonephritis may be of any form, can lead to chronic kidney disease, and especially remember rapidly progressive glomerulonephritis, which can very rapidly lead you to chronic kidney disease. Then interstitial nephritis like drugs, toxins, and infections, obstructive uropathy, stones, vesico-ureteric reflux, and stricture, and congenital polycystic kidney disease. You see, here, diabetes and hypertension are the most common causes, followed by glomerular diseases. Any form of glomerular diseases may be nephrotic, nephritic. If not adequately treated, can lead to CKD. Any form of tubulointerstitial disease may be due to drugs, toxins, or infection, can lead to chronic kidney disease. Any form of obstructive uropathy or post-renal uh, conditions like stones, vesico-ureteric reflux structure can lead to chronic disease, kidney disease if not adequately treated. And of course, congenital diseases can lead to chronic kidney disease. The most important example is polycystic kidney disease. These are the common causes of chronic kidney disease, and as I told you, diabetes and hypertension constitute almost 70% of causes. Now, what are the clinical manifestations of chronic kidney disease? Stage 1 and 2 are usually not associated with any symptoms due to decrease in GFR, because in stage 1, GFR is more than 90, and whereas in stage 2, it is between 90 to 60 ml per minute. So the manifestations of chronic kidney disease, the clinical manifestations of chronic kidney disease like uremia or other symptoms are usually absent during the stage 1 and stage 2 of chronic kidney disease. Now, stage 3 and 4, clinical features, whatever the clinical features the patient presents with, are related to the complications of chronic kidney disease. For example, the common complications of chronic kidney disease are anemia. This anemia can lead to fatigue, decrease of appetite, and shortness of breath. Abnormalities of calcium and phosphorus homeostasis may lead to bone pains, fractures, etc. Water, electrolyte, and acid-base abnormalities. Stage 5 is progression of CKD to end-stage kidney disease or ESKD, when the GFR is less than 15 ml per minute, and then the most common manifestation is uremia. Uremia is not a disease, it's basically a syndrome. It is called uremic syndrome. And renal replacement therapy in the form of dialysis, transplantation, may it be hemodialysis or peritoneal dialysis, becomes almost mandatory. Now, uremia is a clinical syndrome incorporating all signs and symptoms seen in various organs of the body. In fact, uremia or the increase of urea or accumulation of the waste products in the body, it leads to a syndrome which affects almost any body system, and they are grouped together as uremia. Now, before proceeding further with the clinical manifestations of chronic kidney disease, I would like to discuss in slight detail the stage 4 of chronic kidney disease when the GFR is between 15 to 30 ml per minute. Now, this is the stage which will ultimately lead to stage 5 requiring renal replacement therapy. Once the patient is in stage 4, it is very unlikely that he will stay in stage 4 and continue with the conservative management. In fact, when the patient is in stage 4 or GFR between 15 to 29 ml per minute, one should start preparing for the renal replacement therapy. And in this regard, you need to counsel the patient and the family regarding the nature of the disease and ultimate modality of treatment which will be available, alleviate fears. Once you see, when you tell somebody that now your kidneys are hardly working less than 30 ml, 30%, then there is a fear. Oh, then now I have to go for dialysis. So in this situation, it is always better to alleviate the fear, to take the patient through a different dialysis centers or their acquaintance with the patients who are already on dialysis. We also have to screen patients and vaccinate them for hepatitis B and C, because any procedure of renal replacement therapy is a blood-related procedure, and there are chances of transmission of hepatitis B and C. And if we have already screened them in advance, we may be able to vaccinate them and protect them against hepatitis B and C. And finally, we have to discuss the various options available for renal replacement therapy, like maintenance hemodialysis, which is a most commonly used modality of treatment for patients with end-stage kidney disease, CAPD, yes, continuous ambulatory peritoneal dialysis or kidney transplant. This we will be discussing in the subsequent lecture when we will discuss renal replacement therapy. But for maintenance hemodialysis, it is always better to prepare vascular access because we do require blood for hemodialysis, and it is always better to prepare vascular access, that which is called AV fistula, in advance. Usually, AV fistula once made takes 6 to 8 weeks to mature, so we have got the time and we avoid the need for temporary vascular access in the form of tubes, double lumen catheters, etc. And finally, we have to arrange the resources because all modalities of treatment like hemodialysis, CAPD, and kidney transplantation are quite expensive. And most of the patients in this part of the world are unable to afford the treatment. So we also have to arrange for their resources, maybe through charity or through philanthropic organizations or through government. Now, this diagram shows the uremic symptoms. You can see very well see from the diagram that almost the entire body is affected when person develops uremia. Again, different manifestations of the uremia, psychiatric, cardiovascular, cardiac, gastrointestinal, fluid electrolytes, metabolic, all the complications can be seen in patients with uremia. This we will be discussing in detail. Now, this is the list of clinical manifestations in which patient may present with chronic kidney disease, depending on the stage of the chronic kidney disease. In the stage 1 and 2, as I have already told, that symptoms are usually not there. But as patients proceed to stage 3 and then 4 and 5, all the clinical manifestations manifest themselves. First of all, we will discuss urine output, metabolic disturbances, electrolyte imbalance, hematologic abnormalities, cardiovascular abnormalities, respiratory abnormalities, gastrointestinal abnormalities, neurologic manifestations, reproductive systems, renal bone disease, and dermatologic manifestations. Almost entire body and entire body systems are affected in patients with uremia. So let's proceed. Urine output. In the initial stages, patients are not oliguric. In fact, they are passing either a normal amount of urine or they are polyuric because the tubular function is intact in the early stages of chronic kidney disease. But the urine patient is unable to concentrate the urine, and most of the time, specific gravity becomes fixed, 1.010. Oliguria develops as the disease progresses, and stage 3, 4, and 5 patients are usually oliguric. Inuria is urine output less than 100 ml in 24 hours, and patients are usually on renal replacement therapy or in the stage 5 of chronic kidney disease. So polyuria in the early stages, oliguria in the middle stages, and inuria is a feature of terminal stages of chronic kidney disease, stage 4 and 5. Now, what are the metabolic manifestations? Because most of the metabolic manifestations are because of the accumulation of the waste products, because of decreasing GFR, resulting in increase in urea and blood urea nitrogen and creatinine. And the contributing factors for the increase in BUN and creatinine are the increased protein intake, fever, steroids, or increased catabolism due to any cause like fever, stress, etc. There is lack of appetite, nausea and vomiting, fatigue, lethargy, shortness of breath, headache, impaired concentration, drowsiness, and ultimately a very late stage in which there is uremic fetor, uremic smell from the breath of the patient, or there is a uremic frost. I will be showing you the diagram of uremic frost. Now, what sort of electrolyte imbalances can occur in patients of chronic kidney disease? Sodium may be normal, low, or high. If the patient is hypernatremic, it is usually due to sodium retention and dehydration, resulting in hypernatremia. They may be hyponatremic because of water retention and edema, which is also called dilutional hyponatremia. Now, hyperkalemia is a very serious electrolyte disorder, which may lead to fatal arrhythmia. Bicarbonate is usually low in these patients because kidneys are unable to excrete acid load. With this, we have already discussed. But here you have to remember one thing, that the metabolic acidosis of renal tubular acidosis is not acidosis of chronic kidney disease. The pathophysiology of acidosis in patients of chronic kidney disease is different from the pathophysiology of metabolic acidosis in renal tubular acidosis, because here there is a failed kidney buffer, decreased bicarbonate and metabolic acidosis. Now, the hematologic abnormalities, they are very common in the patients of chronic kidney disease. This we have already discussed. Anemia is normocytic and normochromic because of decreased production of erythropoietin. There is a bleeding tendency because of defects in platelet. Although the platelet count is normal, but the ability of the platelet to do its function is impaired, and there is defect in the platelet function. Changes in leukocyte functions because of altered immune response, infections, and decreased inflammatory response. So anemia is the most common hematologic abnormality, followed by bleeding tendencies because of defects in platelet functions or in leukocyte function. Now, the cardiovascular abnormalities are commonly known as cardiorenal syndrome. Most of these patients are hypertensive, and hypertension leads to left ventricular hypertrophy, ultimately leading to heart failure, congestive cardiac failure, or they may present with acute left ventricular failure, especially those patients who are oliguric and anuric, and if they have taken a large amount of fluids, they can present with heart failure and acute left ventricular failure. Peripheral edema can be because of congestive cardiac failure, or maybe because of hypoproteinemia as a result of decreased adequate intake of food and albumin. Arrhythmia, as I have already told you, hyperkalemia can lead to arrhythmia and uremic pericarditis, because whenever the patient is in uremia, and if the kidney functions are grossly deranged, we may present with pericarditis, which is again an emergency. Respiratory abnormalities, they can be dyspneic because of many reasons like anemia, acidosis, or fluid overload. Anemia is common in chronic kidney disease. The patients are acidotic, and if they take a lot of fluid, they can present with left ventricular failure. Pulmonary edema, left ventricular failure can also be a presentation. Uremic pericarditis, we have already discussed. Uremic pleuritis and pleural effusion are also seen in patients with same chronic kidney disease. And the same pathophysiology works here also in the development of pleural effusion and pleuritis, that is low proteins and excessive fluid. And respiratory infections because of decreased leukocyte functions, they can present with, they are immunocompromised, and they can present with respiratory infections. This can also be a cause of shortness of breath. Now, the gastrointestinal abnormalities I have already discussed: nausea, vomiting, anorexia, mucosal ulceration and stomatitis, gastritis, and GI bleeding because of various reasons. The toxins are accumulating in the body and decreased platelet functions. Constipation is also there in some patients because they are not taking enough food. Diverticulitis and lower GI bleeding result because of long-standing constipation, and angiodysplasia may lead to very serious GI bleeding. Now, the neurological manifestations are also there related to increased nitrogenous waste products like urea and creatinine, electrolyte imbalance, metabolic acidosis, ultimately leading to the demyelination of the nerve fibers. They can present with peripheral neuropathy, restless leg syndrome, muscle twitching and cramps, altered mental status leading to irritability. They may present with seizures or uremic coma, especially in patients who have got very high urea creatinine. Reproductive function, there is sexual dysfunction, decreased libido. Infertility is common in both sexes, low sperm count, and menstrual disturbances in female. Now, renal bone disease, which is called renal osteodystrophy, it is basically because of decreased activation of vitamin D to vitamin D3. resulting in low calcium, high phosphorus, and raised alkaline phosphatase, mainly because of secondary hyperparathyroidism, which may lead to tertiary hyperparathyroidism. And the lesions are called osteomalacia, osteoporosis, and osteitis fibrosa cystica, resulting in weak bones and increased risk of fractures. Now we will be discussing the pathophysiology of renal osteodystrophy. Now you see, when there is a kidney failure, there is decrease in GFR resulting in decreased phosphate excretion resulting in hyperphosphatemia. Similarly, because of kidney failure, there is decreased activation of vitamin D2 to D3. This results in impaired absorption of calcium from the gut, decreased serum calcium level, and as a negative feedback mechanism, PTH is stimulated, resulting in osteitis fibrosa cystica, bone demineralization because of raised PTH, result in osteomalacia, and ultimately metabolic bone disease. Again, the pathophysiology of renal osteodystrophy, this you can study and discuss in detail. Now this is a X-ray showing the fracture of the femur in a patient with chronic kidney disease and very osteoporotic bones, no calcium in the bones. Skull, again, decreased mineralization of the skull, giving a paper thin skull features in patients with chronic kidney disease. Again, the fracture of the femur, osteoporotic bones, decreased mineralization of the bones, rugged jersey spine, increased disc spaces. Now, the dermatologic manifestations are also common in patients with chronic kidney disease. They may present with dry, pale skin because of anemia, pigment retention. Once you look at the patients of chronic kidney disease, you can easily say that he has got chronic renal failure because they have got sallow complexions, pigmentation, etc. There might be scratch marks because of pruritus as a result of hyperphosphatemia. They have dry, brittle hair. Fatigue and ecchymosis is also seen in patients with chronic kidney disease because of platelet dysfunction, thin nails, half and half nails. This I will be showing you. Signs of malnutrition like muscle wasting, pedal edema, and ascites, and at very late stage, uremic frost. Now this is half and half lens. You see, only by clinical examination, you can easily make out that patient has got chronic kidney disease. They are also called Lindsay nails. Lindsay nail, Lindsay, Lindsay nails, a characteristic feature of advanced uremia or advanced chronic kidney disease. Ecchymotic patches because of platelet dysfunction. Scratch marks because of intense pruritus. And this is a figure of uremic frost, very white flakes of white material, which is mostly ammonia. And these patients are usually in coma. Nowadays, this advanced stage of uremia is usually not seen. Now, how do we investigate chronic kidney disease? As I have already told when we discussed the investigation in renal disease, we have to perform a renal profile. This includes CBC to find out the type of anemia, platelet count, etc. Urea creatinine electrolytes are the measures of kidney function test. Calcium, phosphorus, alkaline phosphatase to exclude renal bone disease. Serum albumin to find out if the patient is catabolic or if the patient is malnourished. Serum uric acid is usually raised in these patients. We have to perform fasting blood sugar, HbA1c, because most of the patients, almost 50% of the patients with chronic kidney disease suffer from diabetes. Similarly, fasting lipid profile, urine DR culture to exclude infections. And in imaging, we do ultrasound, KUV, if needed, CT scan and MRI. Radionuclide scanning like DTP and MAC3 scans, but they are usually not performed. unless the diagnosis is in doubt, to exclude obstructive uropathy, cystoscopy, and finally, when the diagnosis is in doubt, one may resort to kidney biopsy. But most of the time, the need for kidney biopsy does not arise because lab features and the clinical features of the patient points towards chronic kidney disease. But whenever you are in doubt, you may perform kidney biopsy because if somebody has got an ultrasound showing a small bilateral lesions on kidneys, then there is no need for doing a kidney biopsy because the diagnosis is obvious. Now, how do we manage patients with chronic kidney disease? You don't have to advise renal replacement therapy to all patients of chronic kidney diseases. You have to first calculate GFR and eGFR, and on the basis of GFR and eGFR, you divide patients into different stages. Now, all patients of chronic kidney disease need to be screened for diabetes and hypertension because these are the two most common causes of chronic kidney disease in stage 1, as the kidney functions are not impaired. In fact, GFR is more than 90, you have to treat the cause, for example, diabetes, hypertension, or any autoimmune disease, or any systemic disease. If the GFR is between 60 to 89 ml per minute, you try to delay the progression of chronic kidney disease to stage 3. And this stage is usually managed conservatively by strict control of sugar, blood pressure, immunological disorder, hydration, electrolyte balance, etc. Now, in stage 3, between 30 to 60 ml, you have to treat the complication. If the patient is anemic, you have to give erythropoietin. If the patient's blood pressure is high, you have to treat it accordingly. If the patient has got renal osteoarthritis, you have to use calcium supplements and vitamin D, etc. Stage 4, we have already discussed. We have to prepare patient for renal replacement therapy. And in stage 5, renal replacement therapy becomes mandatory. This is the strategy for managing chronic kidney disease. Stage 1, 2, you delay the progression. Stage 3, you treat the complication. Stage 4, you prepare for renal replacement therapy. And stage 5, you proceed with the renal replacement therapy. Now, management. You see, you can easily delay the progression of the chronic kidney disease, say from stage 1 to stage 2, or from stage 2 to stage 3. By strict control of diabetes, you have to target blood sugar less than 150. You have to control blood pressure, target blood pressure between 120 to 80. If obese, weight reduction, balanced diet, low sodium, low fat, patient should be encouraged to exercise regularly. If he is using tobacco, it should be stopped. And one should always avoid nephrotoxins made in the form of drugs, herbals, hakims, homeopaths, etc. You have to manage the complications and delay the progression. For example, fluid balance, electrolyte balance, correct anemia, correct renal osteoarthritis, and improve nutrition. How do you manage fluid? Intake, you have to maintain the intake and output, avoid fluid overload, which may land the patient into pulmonary edema. To avoid volume depletion, you have to maintain adequate fluid intake. Low sodium diet is usually prescribed less than 5 grams per day. The salt substitute should never be used in patients with chronic kidney disease because all the salt substitutes have got potassium as a salt in them, and which may lead to dangerous arrhythmia. You have to use diuretics, usually loop diuretics and thiazide diuretics are used, and usually they are used in heavy doses because the kidneys are already damaged. You have to use large doses of loop diuretics and diuretics so as to continue. They encourage patients to pass adequate amount of urine. One should always avoid potassium-sparing diuretics in patients of chronic kidney disease. Low sodium diet, avoid hyperkalemia, use only loop diuretics because potassium containing, and they should be educated to avoid potassium containing foods like bananas, citrus, grapes. Organ meat should be avoided, and drugs containing potassium like potassium sparing diuretics should be avoided because hyperkalemia is a very serious disorder and you have to keep a close watch to avoid hyperkalemia. If hyperkalemia due to any reason develops in these patients and the potassium is more than 6, they may end up with arrhythmias requiring emergency treatment in the form of polystyrene bristles known as caxilate powder, or you give insulin, glucose, and calcium gluconate. And if both these measures fail, you have to perform renal replacement therapy irrespective of the urea and creatinine. For metabolic acidosis, low bicarbonate due to increased ammonium excretion, sodium bicarbonate supplementation, sodamine tablet is very cheap, can be corrected. It corrects acidosis and shifts potassium into cells. And it also prevents bone disease. Now, to control renal bone disease, control secondary hyperparathyroidism, which is increase in PTH. This can be achieved with calcium supplementation in the form of calcium carbonate, restricting phosphorus in the dairy by avoidance of the dairy product and use of phosphate binders. Vitamin D supplementations once the phosphorus is controlled between the range of 3 to 4.6, because these patients are hyperphosphatemic. First target is to decrease phosphorus levels in the blood, and only then you can use vitamin D supplementation. And in severe cases, they may be needing paraparatectomy, which is again a major surgical procedure. Paraparatectomy is usually performed for patients with tertiary hyperparathyroidism. And in tertiary hyperparathyroidism, there is both hyperphosphatemia and hypercalcinemia because of very high bone turnover. Now, to correct the anemia, you use erythropoietin. It can be used IV and subcutaneous. The subcutaneous is a better option. The dose is 50 to 150 units per kilogram per week, and one should target hemoglobin between 11 to 12 grams. But before starting erythropoietin, you have to find out the iron status. And these patients, if the iron levels are low, erythropoietin is not going to be of any use. So at first you have to find out the iron status in the form of iron TIBC ferritin, and you should target a transferrin saturation of more than 20%. Transferrin saturation is calculated by dividing serum iron by TIBC and multiplying by 100. In severe cases, and the hemoglobin is less than 6.5, blood transfusion may be needed. We can also supplement with vitamin B12 and folic acid for megaloblastic anemias. And oral iron is usually not used in patients of chronic kidney disease because of poor absorption, and if the patient is iron deficient, IV iron is used. You have to improve the nutrition. Indications of malnutrition are low serum albumin, low transferrin saturation, and low hemoglobin. You should prescribe the renal balanced diet. Renal dietitian can be of great help in these patients. Instead of having 3 big meals, they should continue with small frequent meals, and supplements are usually avoided in these patients, because if they are able to take a small frequent meals, adequate nutrition can be maintained. Protein restriction is usually advised in patients with chronic kidney disease, that is 0.8 gram per kilogram per day. But you see, if we look at our normal population, in fact, our normal population is also not taking adequate amount of albumin. And if the protein is very severely restricted, they may be malnourished with all the complications. So it is always advisable to restrict protein in moderation. In fact, I always tell my patients to take adequate amount of proteins and to avoid the red meat. Protein should always be taken in moderation, and you have to correct GI symptoms by like nausea and vomiting by use of antiemetics, gastritis and peptic ulcer disease by anti-ulcer drugs, and constipation with stool softeners like lactulose. Now, management of stage 5 of chronic kidney disease, when the GFR is less than 15 ml per minute, which is called end-stage kidney disease. Renal replacement therapy becomes mandatory in the form of hemodialysis, peritoneal dialysis, or kidney transplantation. This we will be discussing in the subsequent lecture. But here, briefly, what are the absolute indications for initiating renal replacement therapy? Are volume overload, refractory to diuretics. They are not responding to diuretics, and they are in heart failures. Renal replacement therapy becomes mandatory. Hyperkalemia, if not controlled by conservative management like diet restriction, use of resins, then we may have to initiate renal replacement therapy. If the patient has got severe metabolic acidosis, yes, the renal replacement therapy is indicated. Uremic pericarditis, pleuritis, or encephalopathy, or patient is in coma, renal replacement therapy becomes mandatory. In fact, patients with severe malnutrition, to improve the quality of life, we may have to start renal replacement therapy, with which they can have a normal eating diet. Uremic bleeding can is also an indication, resistant hypertension, severe hyperphosphatemia, severe hypocalcemia. They all are indications, these all are indications for absolute indications for renal replacement therapy. And the rule of thumb is that usually if the patient has got a BUN of more than 100, that is urea of more than 220, and if the creatinine is more than 8, irrespective, even if the patient has got no symptoms, it is always advisable to start renal replacement therapy. Now, finally, the key points of this lecture is early diagnosis of CKD is necessary so as to avoid late stages of CKD by conservative measures. Prompt management, and this can be done with prompt management and timely referral to the nephrologist. These patients require a regular follow-up, so as to we have to monitor their renal function tests, adequate treatment of diabetes and hypertension, because they are the two most common causes of chronic kidney disease. Our aim should be delay progression and treat complications like anemia, bone disease, fluid electrolyte balance, adequate nutrition, and avoidance of nephrotoxins and infections. These measures, to some extent, helps in delaying the progression of the chronic kidney disease, say from stage 3 to stage 4, or from stage 4 to stage 5. And once the patient is in stage 5 or stage 4, you have to plan, prepare, and renal replacement therapy. It is always better to start renal replacement therapy early than late, because in emergency, all the complications, severe complications can occur. This was about chronic kidney disease. You go through it, prepare for it, and next lecture will be on the renal replacement therapy, different modalities like hemodialysis, peritoneal dialysis, or kidney transplantation. You see, renal replacement therapy is the ultimate therapy which in patients with chronic kidney disease, and both hemodialysis and CAPD. I will show you the figures and diagrams and photographs of both modalities of treatment, but it is always better to actually see the procedure. Thank you very much.